So in the state of Oregon, the relationship is really twofold. One is a structural relationship and the other is a working relationship. And the structural relationship was created in 2009 when the Oregon Health Authority was created. And that joined any division in state government that had to do with health. So that was the Medicaid program, as well as mental health, and addictions and substance abuse, and of course public health. So we have been in this journey together under one roof. And that's really been helpful to being able to work on the functional working relationships, because we're in one agency, we sit on the same cabinet, and some examples are, even before we worked very closely around things like immunization, maternal child health, and other areas, school-based health centers, that the population of both the Medicaid population as well as the broader population for the state that public health is concerned about worked on. But now we can really work together on common goals and understanding how to bring tools to the table from each of our perspectives. The culture of public health collaboration in our state, I'd say we really work well together. We understand what each partner brings. And you know, I'm a big believer that in all successful collaborations, even one that seems so intuitive as Medicaid and public health, we have to really step back and be aware that other organizations may have a different mission than we do. And if we understand each other's missions, then it's much easier for us to get to yes around some of the regulatory and benefit issues that we're all concerned about. We have this connection with community-based policies. One good example, I think, is that public health brings to the table the Community Guide for Prevention, the Community Guide for Clinical Preventive Services, which isn't necessarily something that the Medicaid agency and the providers in the state widely use. So we can add that to the conversation. Really concrete example is that when the state of Oregon, in its transformation work, created coordinated care organizations for our Medicaid population. We made a requirement that by statute, the coordinated care organizations had to do a health improvement plan. And first do an assessment and then also do a plan. And what we've been able to collaborate on is, it's in their contract that they have to collaborate with local public health in their jurisdictions. So in our state, we have 36 local counties, 34 local public health departments, and 16 coordinated care organizations. So in those areas, they have to really work together, come together, and the requirement is that they demonstrate that they're working on health outcomes. So both for the Medicaid population and with the population as a whole, based on the epidemiology in that particular area of the state. The other example that I think I would use is the requirement that the CCOs actually do all of this work with a community advisory council, so that the work is done very transparently with this community advisory council. And the community advisory council has, again, in statute a requirement that 51% of its members be Medicaid recipients. So once again, we're bringing the science, we're bringing the clinical care system, we're bringing public health, as well as the real experience of people in community settings to the solutions that a community decides it's going to prioritize for health outcomes. Some of the factors I think that contribute to the success for Medicaid collaboration is, I think that as I've thought about this, we've been on this journey for about 5 years now in Oregon, and for 3 years we've been in the implementation phase. And one thing that I think has really helped, from my perspective, from the public health seat that I sit in, is that from the very beginning, public health was recognized as a key indicator for Oregon's transformation. And it's in our Oregon's Action Plan for Health from the very beginning. So I think that it's important to not look at things right away programmatically, but more, what is the vision that you're trying to achieve across the state? And so as we were doing Medicaid reform, as we were doing different types of working with the hospitals and health systems to drive model of care reform, we always had right up in front that public health and population health particularly had to be part of our vision and part of what we were working toward. That being said, I think what some of the challenges for public health, I think regarding outcomes are, we have to be patient because while you're standing the care delivery system and the incentives and what you're paying for kind of on its head, that's a lot of change. And I think one of the lessons that we learned was that all that change, many balls in the air at the same time, very tight deadlines, lots and lots of money at stake for healthcare systems, healthcare insurers, anybody who was in the Medicaid market, as well as the implications for some of our most vulnerable populations in the state, that we just have to pace ourselves and take time. And I think that once those changes, we're in the third year now, have kind of settled down, what we find is that getting back to Oregon's Action Plan for Health, public health is now front and center of the work that is being done. We are organized in Oregon around the triple aim. And one big foundational corner of that triangle is population health. So, for instance, if we want to save money, we know in the state of Oregon that most of our morbidity and mortality indicators are driven by tobacco use. And now we have people across the spectrum knowing that we have got to do something about tobacco use, or we're never going to bring the cost down, and we're not going to be able to achieve good health outcomes for individuals. As we've incentivized the coordinated care organizations to make the prevalence of tobacco smoking among their own population, as we've incentivized that as part of their dollar rewards at the end of the year, they're all working on that, but they are very aware that they can't do that just in the clinic setting, that they need the policies, the environmental protections that we provide in public health around clean air and the other work that we've done brought to communities around tobacco prevention. And so that's a really concrete connection that people understand the value that traditional and core public health work contributes to the clinical system achieving its goal. And then we know that that being taken care of in the clinical system, we can focus on those broader population indicators that really will make it possible for the whole community to achieve health. So in addition to having tobacco use prevalence as an incentive measure for our coordinated care organizations, we've also used our SIM grant, and we focused on 4 regions. And part of our RFA for that area was you had to apply for the dollars, you had to come up with a project that was based in your community health assessment and the community's goals for an improvement plan. But we didn't decide what that should be across the state. So we have 4 areas, and the other collaboration that was a requirement was you could pick whatever you wanted to work on, like some people are doing the disproportionate share of women who don't get into early prenatal care and interconception care. Another area is looking at opioid use. But they have to do that together. So the coordinated care organization with the Medicaid population and the local public health departments are both coming up with strategies in their own areas that are complementary. And the results that they're measuring together are the health outcomes in that region or in those jurisdictions based on working together across those incentives. Your state's vision for public health, again, has to be right as part of your transformation, has to be integrated. At least that's been our experience in Oregon. You hear a lot about public health trying to get to the table. I think if you're part of the vision and you have the leadership in the state to stay true to that transformation vision, there's no doubt that we're the demand reduction part of the healthcare system. It's our job to let people know how they're doing in keeping people healthy, but also to identify really what those best practices are. That it's very hard. There's a lot of stress with healthcare transformation on individual practitioners and clinicians, and how can we support them in this time of real change for their understanding of their model of care and responsibilities.